This is a panel discussion with our two speakers. It involves why and how you can plan ahead for healthcare circumstances that may arise when you can no longer speak for yourself. In these circumstances, it's important to know who speaks on your behalf, with whom should you communicate your thoughts, your questions, your values. What legal documents should you complete now that will later guide your physician and healthcare team, assuming they read them. It's a really important topic, and we have two phenomenal speakers here to help us decide, Romayne Gallagher and Gerrit, Clements. I just want to tell you a little bit about these speakers and tell you why I laud them so much, because I've worked with them before and I know what they can do. Dr. Romayne Gallagher is a family physician with extensive experience in palliative care. She's currently head of residential care and palliative care divisions of the Department of Community and Family Medicine at Providence Healthcare. She's also physician program director for the palliative care program at Providence. She was a founding director of the Division of Palliative Care at UBC. She was co-chair of Public Information and Awareness Working Group of the National Strategy on Palliative and End of Care Life Care that ended in 2007. This woman is a legend in our business. Gerrit Clements is a health lawyer and health law and ethics teacher with over 35 years experience. He's adjunct professor at the University of Victoria, as well as the University of Northern British Columbia, where he teaches in the School of Nursing. He also teaches at the University of the Fraser Valley and Vancouver Community College. He first started working on the precursor, this is the cute part, he first started working on the precursor of the current Healthcare Consent and Care Facility Admission Act in 1981, and on an attempt to replace the still current Patient Property Act with the Adult Guardianship Act in 1982. It tells you how quickly government works. He's been a member of all the planning and drafting committees for BC's adult guardianship legislation since 1989. He's co-authored several health law publications, including 3 editions of the Guide to the Mental Health Act, Supporting Sexual Health and Intimacy in Care Facilities, and several others. These are two phenomenal people. They're just full of terrific knowledge, and you're going to gain a lot from that. All right, so here's the first question. If you have the power of attorney for a person, you're able to make healthcare decisions for that person. I just got power of attorney for my mom, so can I make healthcare decisions for her? How many people say yes? Well, just put up your hands. Yes. Smattering. How many people say no? The overwhelming majority. Mr. Clements.
Well, I'm very impressed. You know what? You're better informed than some of our politicians. But maybe that doesn't surprise you. You're absolutely right, those of you who said no. It's confusing because in some provinces you can have a power of attorney for financial purposes, but you can also have one for healthcare and personal care purposes. Ontario is such a province. In BC, that's not the case. You can only make financial decisions if you have a power of attorney. If you haven't put anything else in place, then your closest family member gets to make healthcare decisions.
The law allows an adult patient to refuse treatment if they have an illness that can cause his or her death. Okay, so how many people say that that's true? The great majority. How many people say it isn't just for 3? Okay.
Well, the answer is indeed, again, it's correct on the part of the majority. A capable person, the question doesn't say that, but you knew that already, of course. If you're not capable because of an illness, can be a mental disorder or some other kind of illness, and you can't make decisions, then of course you can't make this decision either. But if you're capable, you understand what kind of healthcare condition you're facing, and you say to your doctor, "Doctor, thank you very much for all the information you've just given me. You've given me all the options, but guess what? The option that I choose is not to do anything. Yes, you've told me that it's going to result in my death, but that's what I want." Most people don't want to die, of course, but some people say, many people say, I don't want this particular kind of treatment because it's too burdensome, it's too risky, etc. And if the person can understand those things, then they can make that decision, and then the healthcare providers have to follow that decision, as long as the person is capable.
The physician is legally obliged to treat somebody if they've made a living will. How many people say that's true? Again, it's going to be closer. How many people say it isn't? Okay.
The fact of the matter is that the old, what we used to call a living will, not that it wasn't any use, and not that it doesn't still have some use, but it doesn't speak for itself. Since September the 1st, the government has legislation in place. It's part of that act with a very long name that Art had some trouble with. And you know what? I've tried to say this thousands of times now, and I often stumble across it as well. The Healthcare Consent and Care Facility Admission Act. Since September the 1st, that has a part to it. It's called Part 2.1, called Advanced Directives. And if you follow the format, if you comply with what it says in that act, that the document has to comply with, and I'll say a bit more about that in a moment, then indeed the doctor has to follow it. But this is the advanced directive that follows what the act sets out, it has to comply with. For example, we never used to worry about, most of us didn't worry about witnesses to living wills. Now, if you want to have an advanced directive that speaks for you when you are incapable, you have to have two witnesses, two independent witnesses. And those witnesses can't be your doctor, and they can't be your doctor's nurse or receptionist. It has to be two independent people. And there are a few other things. Now, I'll say this again later on, but if you're familiar with the booklet, actually it's almost a book, that the ministry put out a few months ago, it's called My Voice. Now, I wish it was a little less complicated, but in any event, that sets out what you have to follow. It has a form in it. And if you get the two witnesses and a couple of other things that we will talk about, then indeed your doctor must follow what it says in there. If you say, I don't want CPR, I don't want to be on life support for any length of time, you can put that in the advanced directive. And if it's clear enough, and that's why my plea is to people always, once you've done this, or actually don't write it out yet, go to your doctor or your nurse practitioner or the person on the healthcare team that you trust most and say, this is what I want and this is what I do not want. Do you think that will work? Because you know what? I'm one of these people that gets called by the hospitals and they say, we've got an advanced directive here and that says such and such. What does it mean? Do we have to follow it? And you know, if your healthcare providers don't know what it means, they can't follow it. So it's important to talk to your most trusted healthcare professional about this. But once you've done that, it's clear, and you're refusing something, or you are consenting in advance, and that's something that the doctor can fit himself or herself into and say, yes, that's something that I can do for you, then they must follow that. That's only been since September the 1st.
Who should you present that with? Should you leave it with your family doctor? Should you carry it with you in case you're picked up off the street and something happens?
That's an excellent question.
I know.
Of course, you knew it would be, right? The fact of the matter is that when we first proposed this legislation, which was, as Art mentioned, a long time ago, we wanted to put certain safeguards in, which the government has decided not to implement because it's too expensive. And one of the things that we had proposed was a registry in which you would be able to register any of your documents, even your will, if you so wanted. You can do that anyway, of course, right now. Your power of attorney, your representation agreement, now your advanced directive, so that it could be quickly checked, like those of us that have done a document where you're donating your organs. That works very well. The hospital is supposed to check with the transplant program, and if they find you've got such a document, then they will use your organs. That's something we should have had. in any event, what I plan to do is just to have the most important parts on a card in my pocket and say, you know, this is what I want. And, you know, my wife, my doctor, my sons have copies of this, and check with them if this doesn't work. It should be more user-friendly, but that's the best I can suggest.
I plan not to die, so it's not a problem. Number 4, there's disease and have not made an advance directive. Your family or friends can make one for you.
Your family cannot make an advance directive for you. You have to do that yourself. Now, I'll say a bit later on about other options that we have, of course, where you can write something down which has to be followed by your family. If you don't want an advance directive, but you want your substitute decision maker, your closest family member, to know what you would want them to consent to or to refuse to give consent to, you can do that as well. But you can't, they cannot make such an advance directive that I just talked about for you.
No, that was very straightforward, and everybody got that. Okay, so this one we're going to give to both of our panel members. It is common for elderly persons from certain cultures to prefer that their families make end-of-life decisions for.
Most people would agree that illness is a family affair, right? And so that's why many people think that decision-making is a family affair too. And I think most healthcare providers respect that. What we often forget to ask is to forget to ask people, how do you make decisions? And that's very important for us to do. And it's very important for people to say up front how they would like to do it. And it's very important, so when we come in to ask people that we respect that. So, but I think most of us would have no problem saying, sure, you want your son or your daughter involved, who would you want to be there? And that should be respected. And I can't imagine anybody challenging the law, although, or saying that we had to go by the law. I think we're beginning to realize this in Vancouver because we're a very diverse city and we have lots of different ways of doing things. It wasn't that long ago that many healthcare providers would have said, yes, we absolutely must tell the patient exactly what's wrong with them, when they're going to die, and what they're going to die of. And they have to make all the decisions. And I think now we're a bit more enlightened. I'd also like to say that I think it's not just certain traditions or cultures that value this. It's individuals that value this. And most of us, in fact, would want to run things by our families anyways. It's just that some people prefer to have them formally involved.
Painless death is the goal of all people, regardless of your beliefs. Is that true? Yeah?
What I'm trying to say in this question is that people die as they live. People live in a variety of different ways. People also choose to die in a variety of different ways. And so we need to learn to respect that. I must say, though, if people are particularly frightened about the use of treatments and medications to treat pain, we try and enlighten them so that they might be making a decision from education and not from fear. But there are certain traditions, for example, let's take Buddhists. Some people may value the idea of being clear till the end of their life, and we would certainly try and honor that. And that's what I'm going for again.
Do you want to address that thing, though, about treatment of pain at end of life? I think there is a terrific fear.
There's a huge amount of fear, and there's a lot of, I'm afraid, myths around about the use of pain medications. Probably when a lot of older adults here were growing up, these medications were viewed as very, very deadly drugs that could be extraordinarily harmful. And in fact, many healthcare providers believed that. In the 1940s, the Journal of the American Medical Association gathered a bunch of experts together, and they said, whatever you do, don't use these medications till the last couple of days of life. And so people began to associate this medication with dying, instead of thinking, right, they died of cancer, but we used the medication to keep them comfortable. Now we have shown actually that early access to palliative care, which includes symptom management and pain management, some early articles showing that it helps people live longer. And that makes a whole lot of sense if you think about what a stress pain is on the body. And so we encourage people to use the medication they need to keep them pain-free and to help keep them functioning, because that probably helps them to live longer. These medications used appropriately in those situations are actually remarkably safe. And so I find it difficult when I read about people talking in the paper about, say, OxyContin and all this kind of thing, and talking about the misuse of this substance and confusing it with the appropriate use of this medication to treat pain and symptoms. So whenever you're reading that, be sure what you're reading about, what situation you're reading about.
CPR in patients with serious illness will bring them back to life in 25% of cases. How many people believe that CPR works in 25% of cases?
Well, let's talk about in advanced illness, which we're talking about. So people who've had a chronic heart disease, lung disease, kidney disease, heart failure, a cancer that's spread and metastasized, it's about 5%. If you, and that's 5% of people who are brought back to life and who may live until discharge. I think it's important for people to realize, if you look at the stats, anybody who gets resuscitated in hospital has about a 17 or 18% chance of living until they're discharged from the hospital. But of those 17 or 18%, probably about 40% will have some pretty serious brain damage or will not be able to function like they did before. So when people have serious illness, we generally sort of say it doesn't make much sense for you to ask to be resuscitated because it's unlikely to work. We can only bring you back to the state you were in before you died. And so what I say to people is, you know, when this illness ends your life, we're not going to try and bring you back. And most people sort of say, well, of course not. Why the hell would you do that? But if somebody says, do you want to be resuscitated? That sounds like an entirely different proposition, doesn't it? And that's why it's appropriate that you have this discussion with your healthcare team about what might be appropriate in your health circumstance.
Do not resuscitate it, or do not resuscitate order means that no further treatment will be given to control the disease and only pain and other symptoms will be treated. How many people believe that's true? When you put a DNR on there, that only pain and other symptoms will be treated. How many people think that isn't true, that they'll actually treat everything else? Romayne?
Good, and it looks like there's quite a few I'm not sure's. And I think this is again the very confusing thing, that people think when they're agreeing to not be resuscitated, that they're agreeing to have no further treatment for their disease. Far from that. I like to phrase it to people, we will help you live as well as you can for as long as you can, but when you die, we won't try and bring you back. That doesn't mean that that you could not have treatment, could not have all kinds of things done. And some people even will go to the intensive care unit, but if they die from the disease, they will not be resuscitated. So it really, there are a lot of options for people.
Okay, so how many people think that starvation is a common cause of death in terminal illness? So willfully stopping to eat.
Okay, let's leave it like that. Okay. Let's just leave it like that.
And how many people think that's not true, that everybody eats fully until they die? I certainly plan to.
Oh, but here's the key. I would say most people, okay. So you've thrown a curveball, Art.
Well, keep the evening going longer that way, my dear.
I think it's really, most families would like to see their relative eat till the moment they die, right? But in reality, what happens is with an advanced illness, most people are not hungry. And so they will often stop eating days or weeks or even months. They will only go with small amounts of fluids and food. And this is quite natural, but it worries the heck out of families, right? And so just the other day, there was an article written in the Medical Post about people starving themselves to death, which I think is pretty frightening for people because we picture people who are really, really hungry, who are unable to get food. And that's not the case. What we do see is families thinking that they're helping their loved ones by feeding them, and that this will help them to get better or help them to live longer or help them to pass more peacefully, or, you know, a number of reasons. But in fact, this often turns into a bit of a family battle over, you know, to feed or not to feed. So we usually encourage people to kind of, when the person has advanced disease and their body's telling them not to eat, that's a pretty natural thing that the body does in preparation for dying. And it actually reduces the number of symptoms people get, like bloating and stomach pain and difficulties and vomiting and so on. We see if people just eat what they wish to, or they can, even if it's Purdy's chocolates or a glass of wine, it generally makes for a happier time and fewer symptoms.
Oh, you hit that curveball very well. This one, this is an interesting one. Dementia is a terminal illness. If we put down causes of death, would we put dementia down as a cause of death for somebody when they, as the final diagnosis? How many people would say yes? Okay, I think you guys are going to get this wrong. I don't know what Romayne's going to say. How many people would say no? All right, Romayne.
It's very interesting, isn't it? And I could speak to our resident geriatrician here, but dementia is a terminal illness. And we have data to show this.
In the United States, I think I just saw
yes,
this. So
and
listed
you know why I think people are often misled by this is they think, oh, dementia is a problem with the memory, isn't it? And then, you know, they don't move around very much and they don't eat very much and they die of pneumonia. In fact, dementia involves the whole brain, and the whole brain is progressively involved with this, and so the dementia affects first their memory, often then their ability to do everyday tasks, later on their ability to walk, and in the later stages their ability to swallow. And so often people end up having a final event of an infection, but that comes because their body is not mobile and not working properly. So dementia is indeed a terminal illness. And it's very important for people to kind of think that when they're diagnosed with dementia, that they early on make plans about the end time, because that's what we'll talk about later, because that's really helpful for their families.